questions and answer. But if you have a question, please type it in the chat pane, and then Rahul will marshal them and we'll go through the questions at the end. But if you really want to talk to the speakers at the end, please raise your hand and we'll look out for you so that we can give you the microphone. And the talks will be available with the speaker's permission on the website, which is in the link that you can see on your screen and which is available in the email correspondence that you'll have had. So Max, if you're ready, I'm going to ask you to kick off. Hopefully Ola can join us later on, but I'm going to ask you to kick off with your talk.
Okay, I am going to open the presentation of Ola and start presenting Ola's presentation, because I had to cut it down a little bit because I had only one part of it. So I am opening now the Ola's presentation, and I hope to be able to share it with you.
Yeah, you can share it. Yeah.
Can you see it now?
Yes.
Yes, yeah.
Can you maximize
European
that?
guidelines? Yeah. Can you see it?
Perfect. Yeah,
so
perfect.
I am sorry if I have some doubts about Ola's part, because I haven't practiced it as much as my part, but I will start, and I hope that Ola gets on time. So what we are presenting this morning is the European guidelines for the management of respiratory distress syndrome. The last version that was published in 2019 in neonatology. I have this disclosure to make. We were a consultancy fee for KSI Pharmaceutical. The learning objectives of this presentation is to understand the current controversies in respiratory distress care syndrome care, the gain of knowledge in the methods for guideline preparation using the GREAT methodology, to share the 2019 European RDS guideline recommendation with you, and I would like to introduce you to the guidelines group, which has the aim of discussing controversies in RDS management, examine the evidence for best practice, report on consensus recommendations for the European Expert Group of Management on RDS, and these guidelines are endorsed by the European Association of Perinatal Medicine of the European Society for Pediatric Research. They first convened in 2005. They were first published in the Journal of Perinatal Medicine, and they have been updated in 2010, 2013, and 2016 in neonatology, and now the last version is one that we are presenting today in April 2019. Here you have the list of the previous publication. My personal participation was in the last 3 editions, and Ola has participated in all of them. Here you have the citations. I would update the 2019 citation is already going over the 200 citations, and is a very well-known and follow guidelines in Europe. Neonatology is a journal that is very broadly read in Europe, especially more than in America. I don't know about Australia, and our recommendations are followed quite closely by most of the European neonatologists. We based our recommendations are based on the strength of evidence using the GREAT method, when we put the A is the strongest evidence, that is a randomized control trial, or the D evidence is the lowest evidence, which is the expert opinion. And we subgrade them, the A for A1 or A2, depending on the evidence that supports one of the each one of the recommendations. It is irrelevant to show or to say that, yeah, excuse me. It's important to underscore that many of the guidelines and many of the treatments that we are using in neonatology are not based on a high evidence. And this is something that should be underscored, because we are seeking in our search for the guidelines, we're seeking for a long period of time, almost 2 years. A group of people are searching this information or in trying to find the most relevant publications in each of the fields that you have here: prenatal steroids, oxygen, non-invasive support, mechanical ventilation, surfactant replacement, and general supportive care. This is the publication in neonatology. Here is the reference, and it's an open publication, so you can download it for free. And here you have the team of people that we meet. Now we do it online. Before we used to meet in a European city for several times, and we each one of us had assigned a part of the guidelines, one of the issues. Like Ola and I, we were more devoted to the part of resuscitation. We review everything that has been published after the previous guidelines. And as you see here, many European countries, here you have Germany, you have Holland, you have Denmark, you have Spain, France, Italy, United Kingdom, etc. So, and Finland. So you have here a group of well-known neonatologists that have participated. Recent incorporations were Arjen Pas from the Netherlands, which whom you know very well, because he did his fellowship in Australia, in Melbourne, and Charles Christoph Roer, who is the president of the ESPR right now. Here are the issues that we are going to briefly speak about, because it would be too long for 40 minutes to speak. Regarding the first part, regarding prenatal care, our obstetricians in contact or in coordination with us have recommended that mothers below 28 to 30 weeks gestation should be transferred to perinatal centers. We have done a European study in which it has been shown that centralization of perinatal care is one of the strongest inputs that has improved our standard of care. We should offer a single course of antenatal steroids to women at risk of preterm delivery from when pregnancy is considered viable up to 34 completed weeks of gestation, at least 24 hours before birth. A1 recommendation, highly strong recommendation. A single repeat course of antenatal steroids may be appropriate if the first course, since from the first course more than 1 to 2 weeks prior and the duration of pregnancy is less than 32 weeks. This is something that is still on discussion, but it's being quite frequently applied in Europe. If 2 weeks have passed and the baby is in less than 32 weeks and we don't have a delivery that is going to succeed rapidly, then many obstetricians are giving a second course, always with high control of development. And antenatal magnesium should be administered as a neuroprotective agent. considerations in the delivery room stabilization. Regarding cord clamping, well, delayed cord clamping is one of the last innovations, I would say, in the delivery room, since although it has been done for many, many years in many settings. We know that in the first 2 minutes, almost 90% or 95% of blood from the placenta is transfused into the fetus. Even just with 1 minute, we get more than 85% of blood. So the effect of delayed cord clamping was reviewed by Fogarty in the American Journal of Obstetrics and Gynecology, and he did a meta-analysis. He included the 2,834 infants less than 37 weeks of gestation and almost 1,000 babies less than 38 weeks of gestation. And just by clamping the cord more than 1 minute, it was shown a highly beneficial effect, as you see in the plot, in the scatter plot. So,
Max, I'm just going to interrupt. I think Ola has just joined us. And
okay.
I wonder if Ola is able to take over from where you've got up to in the talk. Ola, can you hear me?
Yes, I hear you. So I am. Good morning. I'm sorry. I I was up, but I thought it was 1 hour later.
That's
so
okay. Don't worry.
Very
So Ola, we're
Yeah.
going to give you the screen. If you can take over from this part of the talk that Max has been doing on your behalf, that would be great.
Okay. Did you do the introduction?
Yes,
Max?
Yeah,
he's done
I already did.
The first 10 slides or so.
I am talking about this is anyhow this is my part, William.
Oh, okay.
Yeah.
Well, in that case, let's carry on, and then we'll hand over to Ola when it's appropriate.
Yeah.
Okay. So the only thing is that I had done some changes in the presentation in my presentation. If you don't mind, I change to my presentation. Is it a problem?
No, that's fine. Go ahead.
Well, okay, I'll go on because this is yeah. So we were talking about delayed cord clamping. Yeah. So delaying cord clamping by at least 60 seconds saves lives. So it is important to insist with obstetricians, especially and midwives, that delaying cord clamping at any gestational age is life-saving and improves the quality of survival. There is another approach, which is cord milking. Cord milking is done, has been usually done in emergency situations. The cord is clamped as close to the placenta as possible, and then the cord is stripped several times so that the blood contained in the umbilical cord is transfused to the baby. Experimental studies have shown that by doing this, you increase substantially the amount of blood, the bulimia of the experimental animal, but there is a brisk increase in the pressure in the cerebral circulation that can lead to damage to the vessels and some hemorrhagic consequences. So it should be perhaps taking into consideration that cord milking may be dangerous, and only in extreme situations perhaps may be done. So we don't recommend it as a routine procedure. There is a physiological based cord clamping in preterm infants, and this is something that the Australian physiologists have developed, especially the group of Stuart Hooper. And the fundament is that the baby starts breathing with the intact cord, and so it allows while the lung is expanding, it allows a transfusion of blood that is going to improve the preload of the heart during the first breaths, allowing the heart not to pump in void, but and to have an important afterload to the lungs. So it stabilizes more rapidly the cardiocirculatory lung circulation. So this has been shown in our recent publication in Journal of Pediatrics, when we see that babies that are breathing spontaneously with intact cord, they have a much better SpO2. The SpO2 reaches a stabilization, and the heart rate reaches stabilization much earlier, and without the need for any sustained inflations or any resuscitation measures. The objective of the several trials that are going in Europe regarding the physiological based cord clamping, the first objective is to prove the feasibility of this new approach. They are several randomized controlled trials going on in different centers, especially in Holland and in Germany. And the primary outcome is the time needed to stabilize the infant starting from birth. Stable is defined as establishment of a regular spontaneous breathing, heart rate greater than 100, SpO2 greater than 90, with an FiO2 lower than 0.4. Here you have the very sophisticated device that the Dutch have developed. It's called the Concord device. Is the group of Leiden that has developed it. And the good thing about this device is that you can adjust it perfectly to a vaginal delivery, or you can adjust it to a C-section, and it has all the means that you need, all the devices that you need to stabilize temperature, pulse oximetry, positive pressure ventilation, etc. So you have everything built in one device. Regarding sustained inflation, there were many small trials in Europe, even an interesting trial done by the Italian Neonatal Society. They aimed to improve the ventilation in the delivery room, to expand the lung by giving 20 to 25 centimeters of water for 15 or 20 seconds. A couple of times, 2 or 3 times. So they proved in different small trials, and at the beginning, in the first studies that we knew by Lindner and by other Italian Lista, by Lista, etc., they had several papers with good results. However, the SAIL trial, which was the big trial designed to prove that sustained inflations were beneficial for the baby in the delivery room, and afterwards for reducing bronchopulmonary dysplasia, didn't show those benefits. And in fact, the SAIL trial had to be stopped because there was an increased mortality. There were early deaths in sustained inflation arm. So regarding sustained inflation, we didn't see any beneficial effect in the delivery room, like Apgar scores at 5 minutes, intubation in the delivery room or afterwards in the NICU, the oxygen needs, mechanical ventilation, or relevant clinical outcomes such as BPD, ROP, etc., didn't didn't benefit from the use of sustained inflations. And moreover, it may have potential harm, as shown by the Sail trial. The higher or lower oxygen for stabilization is an issue that is a burning issue in this at this moment. Two very recent studies have made a comprehensive review and meta-analysis of all the trials that have been done. The one by Ki Lui from Australia, from Sydney, the Cochrane review showed that there weren't any differences for mortality, near-term corrected age, or at discharge in depending of giving as initial FiO2 of more or less than 0.4. So what we found is that independently of the initial FiO2, if it was high or low, the mortality was similar. So starting with FiO2 high or low makes no difference on mortality in preterm infants. However, and this is important, when we look at the lower gestational ages, and we are speaking of babies of less than 27 weeks of gestation, we see that babies in this group have more difficulties to reach SpO2s higher than 80 at 5 minutes. And this is associated with higher mortality. So in babies extremely low birth weight or low gestational age babies, we should be very aware that very frequently we will need to increase FiO2 to 40 or 50 in the first minutes in order to reach those saturations that assure a better outcome in the delivery room. Regarding the use of high flow nasal cannula as a primary support in the delivery room, the study by Roberts in New England Journal of Medicine had to be stopped at 564 babies instead of the planned 750 for an excess of failure in the high flow nasal cannula group. So this shows that the better approach for stabilization or respiratory support in preterm infants in the delivery room is mainly the use of the traditional CPAP. This is the best way, and we should be aware of the details in each hospital. They should establish their own rules for doing that. Well, the summary of this part, which is my first part, is we should consider with an A1 grade delay cord clamping for at least 60 seconds. Oxygen should be controlled by using a blender. An initial FiO2 of 30% is appropriate for babies less than 32 weeks of gestation. And remembering that the very small ones may need a little more oxygen in the first 2-3 minutes, and 21 to 30% for those between 28 and 32 weeks of gestation, and the adjustment should be guided by pulse oximetry. In breathing babies, stabilization with CPAP with a pressure of 6 to 9 via mask or nasal prongs is adequate. We prefer the TPs, which enables to control the PEEP much better the PEEP, and is recommended rather than self-inflating bag or flow-inflating bags. Sustained inflation should not be used. Intubation should be reserved for babies who have not responded to positive pressure ventilation via face mask. And plastic bags and occlusive wrapping and the radiant warmers should be used during stabilization in the delivery suite for babies less than 28 weeks gestation to reduce the risk of hypothermia. And this is my part, and we pass on to Dr. Saugstad for the next part of the presentation.
Okay, do you hear me?
Yeah, we hear you. Yeah.
I guess I have to share my screen.
Maximo, can you shut your screen down? Shut your share screen down.
Yeah, I'm trying to.
Oh, yeah, that's right. Can we give Ola the screen now? Or we go back to Maximo's screen. Max's screen.
I cannot do anything. I am not controlling my screen.
Oh, okay. Rahul?
Yeah.
Rahul, we need to give the screen to Ola.
Yeah, I'm gonna, yeah.
Yeah.
I think there's
Okay.
there's a red sort of a button on the top. If Max can press that, yeah, done.
Yeah, no? Okay.
Yeah, and Ola can share his screen. No.
Yeah.
Well, if you press the green button for share screen, you'll have control of the screen. The green button at the bottom.
I have, you see this now?
No, there's a green button
Yeah.
at the very bottom
Oh,
of your screen.
I have to find my presentation.
Oh, okay.
I put it here. Let's see now. You see this?
No, not yet. You have to share screen first.
Yeah, I did that. Oh, or maybe one more.
Yeah.
Now we can see your screen.
Okay.
Choose the file, and we'll see what you have.
Okay. Yeah, here we go. Now you see it.
Yes,
And
you can see that. Yeah.
And I had to scroll
Can you
down.
maximize that?
To my part. Here. So here we are.
Can you maximize that? Oh, that's great. Thank you very much.
It is, yeah. So, well, good afternoon, everyone in Australia, and thank you for giving me this opportunity to share this work with you. I'm sorry I missed the time. I was up for several hours, but I thought it was 1 hour later, so that's my big mistake. Anyway, I have been part of this European group since 2005, 2006, when we started to give out these European recommendations. And I guess Max told a little bit about the process, but I just want to say that we work as a group. We have our specialities, and we present our topics for each other and discuss at meetings. We start to prepare the next guidelines approximately 1 year ahead. So at the end of 2021, we have started on the 2022 guidelines. They're coming out every third year, as you know. So I will talk about surfactant. And when we made these guidelines, there were several considerations we had to take into account. Should we give it as a rescue or prophylactically? And which administration method should we choose? As a bolus, as Insure, as Lisa, mist? And what kind of preparations should we use, and when should we give surfactant? And should we add sedation? So these are the considerations we discussed. And as you understand, we try to base our recommendations on the evidence base. So we're looking up Cochrane reviews and other meta-analysis, systematic reviews and meta-analysis. And this is review, which I guess most of you know, the Cochrane review by Royas Reyes from 2012, when they analyzed the effect of prophylactic versus more selective use of surfactant. There was seems to be a shift, because 20 years ago, around the turn of the century, everybody agreed that we should give surfactant prophylactically. But then after this review here, showing that there's a better outcome if we give it selectively on the indications. I think we stopped to recommend prophylactic surfactant, and there's several reasons for that, and one is that more babies, for instance, receive more antenatal steroids. So we have a different population now than compared to 20 years ago. So here you see that the outcome from BPD favors using surfactant selectively. And here is the same study, but the outcome here is mortality, and again you see that there is an advantage to delay the surfactant installation until there is an indication. So this is our recommendation: prophylactically intubating and giving surfactant to all babies increases the risk of BPD. So what about Insure and early rescue? Well, this is a summary by Stevens and Blenov. It's a Cochrane review from 2007. And it shows that Insure versus rescue and ventilation has several advantages. It doesn't reduce deaths in this study, but it reduces need for ventilation and use of surfactant, and also reduces air leak. So based on this, we concluded that using Insure compared to surfactant and ventilation reduces need for ventilation and bronchopulmonary dysplasia. Now, what about the newer modes of administration as less invasive surfactant administration versus intubation and surfactant delivery? This is a meta-analysis, a systematic review published some years ago now, 3 years ago, and it shows that the need for mechanical ventilation is reduced using LISA, the less invasive surfactant administration. And here is the composite outcome: death or bronchopulmonary dysplasia at 36 weeks. And again, we see that this favors LISA compared with the older administration form. So based on this, we concluded that LISA is better than intubation or INSURE at reducing need for ventilation and reducing BPD. So when should we intervene with surfactant? When should we give surfactant? Should we give it early or should we give it late? And again, this is a Cochrane review some years ago now, but I think this was the last we had when we did this most recent guidelines. And here's the outcome: chronic lung disease or death at 36 weeks. And again, if you go down here, you see relative risk 0.83, confidence intervals 0.75 to 0.91, favoring the early surfactant administration. So based on this, we recommend that if surfactant is required, the earlier it is given, the better the outcome. And then what is the indication for giving surfactant? Well, we have picked an FiO2 of 30% or more. It's based on Peter Dagerbill's data some years ago now. It seems that babies who need FiO2 of 30% or more have a greater risk of CPAP failure. So what Peter did was that he investigated almost 300 babies less than 32 weeks and divided them into CPAP success or failure within 72 hours. And CPAP failure predicted by highest FiO2 in the first hours of life. And those failing CPAP had a worse outcome. And it seemed that 30% was a cutoff. So that's why we have chosen that. Now, which surfactant should we give? There are several surfactants on the market in Europe. And here is, again, a Cochrane review comparing bovine minced lung versus porcine minced lung surfactant. What you see here, this is outcome here is death or oxygen requirement at 36 weeks post-menstrual age. And what you see here is that this systematic review favors porcine surfactant. Relative risk for this outcome, 1.39, with confidence interval from 1.08 to 1.79. So based on this and some other studies, we concluded that natural surfactants are broadly equivalent, except for 200 milligram per kilo prolactin alpha, which is Curasurf, which we believe is better than 100 milligram of prolactin alpha or Beractant or Survanta. So our recommendations for surfactants are the following. Babies with RDS should be given a natural surfactant. A policy of early rescue surfactant should be standard, but there are occasions when surfactant should be given in the delivery suite, such as those who require intubation for stabilization. So if the baby is intubated anyway, we recommend to give surfactant. Babies with RDS should be given rescue surfactant early in the course of the disease. A suggested protocol would be to treat babies who are worsening when FiO2 is above 0.30 on CPAP pressure, 6 centimeter water or more. Prolactin alpha in an initial dose of 200 milligram per kilo is better than 100 milligram per kilo of prolactin alpha or Beractant for rescue therapy. And we also now recommend LISA as the preferred mode of surfactant administration for babies on CPAP. But this provides that the clinicians are experienced with this technique. And sometimes a second and even a third dose of surfactant should be administered if there is evidence of ongoing RDS, such as persistent oxygen requirement and other problems have been excluded. So with this, I hand over the word to Max, if he's there.
It looks like we've lost Max.
No, I'm here.
Oh, hi, Max. Yeah.
Yeah. Okay. Hi. Yeah.
Back to you. Okay.
Yeah. I share my screen and okay. Can you see my screen?
Yes, that's perfect.
Okay. So our part is my second part is will deal with different aspects. One is O2 beyond stabilization. Our review of the literature shows that in preterm babies receiving oxygen, the saturation target should be between 90 and 94. This is all the trials that were done like about 5 to 10 years ago. The 5 trials of the neoprom suggested that higher ranges could lead to increased ROP, and lower ranges could lead to increased mortality and necrotizing enterocolitis. Our group finally decided that we should put our alarms between 89 and 95, 96, and keep the range of saturation, oxygen saturation for preterm babies in the NICU between 90 and 94%. So there are different non-invasive respiratory support methods that can be used in the NICU. We have the CPAP, which is can be in three aspects: bubble, flow driver or prongs, mask, the nasal intermittent positive pressure ventilation, also in three different modalities, and the high flow nasal cannula. We have done an analysis on to see which was the best, for example, for extubation failure. And here you have, you see, when we compare especially synchronized nasal intermittent positive pressure ventilation versus CPAP, there is a better results in order to avoid the failure of extubation when using an IPPV compared with CPAP. So in IPPV, our conclusion was that it's better than CPAP for keeping babies off mechanical ventilation following extubation. It's also, we have also reviewed the Cochrane review by Lemire in 2017, and it showed also that synchronized nasal IPPV or even non-synchronized was better to avoid chronic lung disease. Regarding high flow nasal cannula for extubation failure versus CPAP, it was shown that CPAP is better than high flow nasal cannula for very preterm infants. But when we speak about babies above 28 weeks of gestation, high flow nasal cannula are broadly equivalent to CPAP for babies of these gestational ages, and it is easier to manage and more user-friendly. So we concluded that high flow nasal cannula could be satisfactorily used for avoiding extubation failure in babies of this gestational age. So when dealing with non-invasive respiratory support, CPAP should be started in all babies at risk for RDS who do not need intubation for stabilization. And this is an A1 great recommendation, so a strong recommendation. The system delivering CPAP is of little importance. It has to be a system, it should be a system in which the unit or the caregivers are experts in the management and have a good expertise. However, the interface should be short nasal by nasal prongs or mask, and starting pressure recommended about 6 to 9 centimeters of water should be applied. CPAP with early rescue surfactant should be considered the optimal management for babies with RDS. Synchronized nasal intermittent positive pressure ventilation, if delivered through a ventilator rather than BiPAP device, can reduce extubation failure. And during weaning, high flow nasal cannula can be used as an alternative to CPAP for babies, especially above more than 28 weeks gestation, with the advantage of less nasal trauma. And this is my part, and I would like to thank you for your attention. On the right, you have Spain, and in the left, you have Norway. You can see both we have sea, but they are a little bit different in the color and in the vegetation. So thank you very much for your attention, and we look forward to your questions.
Thank you very much indeed. And I'd just like to confirm that there's an enormous amount of work that's going on here. Is based on the best available evidence, and I think that's a really good example for the rest of us to follow. We have a question from Dr. Abdel, who wanted to know what the FiO2 threshold for second or third doses of surfactant should be.
Yeah,
Comment on that?
Yeah, I saw that question, and I also looked in the guidelines. We haven't specified that in the guidelines, but we have what we say that the indication for giving surfactant is FiO2 of 0.3. So I guess that's what we mean, but I think it's a good question. I think we should clarify that till next edition coming out in 1.5 years or so. So we haven't written it, we haven't specified it. So I don't
Ola, can I?
This as a comment to that.
Yeah, Ola, could I comment something? There are many neonatologists who agree in the fact and or are trying to gather information in this respect, and perhaps for babies below 26 weeks of gestation, we should be a little bit more aggressive, and if they need more than 0.25, then we should go into the administration of surfactant. That's something that a small study that is going on in the Spanish Neonatal Society is showing that perhaps it should be a better approach, but this we have to look after in the literature.
Yeah, I think this is very good inputs to the next edition. And I saw now another question on the screen: which dose we give when we give repeated doses, and for prolactin alpha we give 100 milligram per kilo. So I think that is the standard repeated dose.
Okay, we have another question from Dr. Marwa Abdel. Will research around lung ultrasound be used in defining the guidelines for respiratory distress syndrome in preterm infants? What's the role of lung ultrasound?
Well, I don't know if Ola wants to answer. I think lung ultrasound in Europe is becoming very, very popular. There are lots of courses, and there are coming a lot of publications coming from the group in Italy by Francesco Raimondi in Naples, and the group of De Luca in Paris. And they are gathering more and more information in order to early detect RDS, but also to analyze the response to surfactant. So I think we are going to include this new approach to RDS in the coming guidelines, because as I told you, there is a lot of information being published and very interesting papers in regarding RDS and ultrasound, lung ultrasound.
Yeah, we briefly mentioned lung ultrasound in the 2019 guidelines. And when I was reading through the guidelines yesterday, again, I was thinking this has to be upgraded in the 2022 guidelines. So I think you will read more about lung ultrasound in the next edition.
Okay, we have a question about ceasing caffeine. What are your recommendations for stopping caffeine? Do you prefer to cease at 34 weeks or continue beyond 34 weeks if the infant is on respiratory support? Max, what's your view?
Yeah, well, we have our protocols for ceasing caffeine are related with the stability of the respiratory stability, the absence of intermittent hypoxic episodes or bradycardic episodes for a week, during a week, 7 days. Okay, so and this is done during the after the baby goes from the NICU into the intermediate care. We support caffeine until the last 34 weeks, but always retire caffeine when we have 1 week of control without having intermittent hypoxic episodes or bradycardia. We have done a study that we are gathering now the results. 7 days, we have over 100 babies controlled for that were less than 28 weeks gestation, and we have controlled heart rate and pulse oximetry minute by minute during 7 days, and we are analyzing the incidence of hypoxic episodes, and we have done the analysis of the use of caffeine or the prognostic factors during these periods. What is more important, the length of hypoxia or the length of bradycardia, or the combination of both. And we have even determined some microRNAs of that affect hypoxic episodes on the brain. So we will have results, I think, quite soon, and we can share them with you.
And just a general question about really the advice that you're giving on the last few questions. What grade, what's the strength of evidence and the grade of recommendations that you're basing these recommendations on, Max?
Yeah, the caffeine has is one of the silver bullets in neonatology, and the grade for caffeine to avoid those hypoxic episodes is A2.
Yeah,
which is a high standard of recommendation.
And I think the point I'm making is being echoed by Peter Dargaville just now on the chat, that we do need to acknowledge that much of the data on which current recommendations are based are on retrospective uncontrolled studies in his case, and no randomized trial has clearly shown that 0.3 is the best FiO2 threshold. So I would really recommend all the younger pediatricians and neonatologists that are listening to this to be very, very careful when you look at recommendations, and to make sure that recommendations that are not based on randomized trials, that you're much more skeptical about them. And they in fact do have a very short half-life. And one of the interesting slides I saw from Max's presentation was that the evidence for surfactant versus CPAP is now very different from it was 2 decades ago. And in fact, it's now reversed. And I think what you'll find looking at the history of the evidence that we have is that when you have trials that have very large numbers of patients that are looking at outcomes like mortality, then the message from those is much slower to change than when you're looking at much smaller trials with maybe 100, 200, few hundred patients in wide confidence intervals and outcomes which are different from mortality. So just a note of caution there. Here's a question from Juan Yi Kong. Is there any utility in assessing the histogram to look at the percentages of time when the SpO2 is out of range in 12 to 24 periods, in addition to setting the target range?
Yeah, well, we use it in, well, this is not, this is out of the recommendations, so, out of the guidelines. So I can only talk about my personal experience. Well, one of the things we want to analyze in the study I just commented, in which we have monitored for 1 week, minute by minute, more than 100 babies, small babies, is to see what is the correlation between what we see in the histograms and the real periods. And we have done a special artificial intelligence approach to analyze this data. And I think histograms are a poor surrogate of what is really occurring with these babies. I think it's a guide to see if we are within a range, but we will probably miss some babies that are undergoing not a long time and not a long time under the recommended SpO2, but there are perhaps short times, but with an intense lower, a more intense lower heart rate. So the combination of lower SpO2 with lower heart rate, despite being for short periods of time, can be more predictive of bad outcomes in the long term than perhaps more prolonged lower SpO2 that are, well supported by the babies with almost normal heart rates. So this is always the combination that I think is important.
Very good. Well, it looks like we're coming to the close of the hour. We don't have any. Oh, there's another question here from Marcus B. Is there a role for automated closed loop oxygen titration in the acute phase of RDS?
In my opinion, I don't know if Ola wants to add something, but in my opinion, the automatic loop is more of an approach for the post-acute phase of RDS, not during the acute phase. During the acute phase, I recommend that nurses and doctors are watching the baby as much as possible.
Yeah, I completely agree with you. I agree with you in that, Max. But I think that the closed loop systems will be much improved. So it might have other new indications within a few years.
Yeah, I'm going to ask if Peter Dalgeville is there. Peter, can you unmute? Can you show yourself? Do you have any comments on the progress of this kind of technology, particularly in the delivery room? Peter.
Yeah, I am here.
Yes, please.
Just at my tennis club about to play. But thanks for the question. Look, I do think the technology has the potential to improve. And speaking in particular of the algorithms that we've developed and refined, we find that it does perform well even in the acute setting and in the first hours and days of life. And there will be further data coming out on the function of that algorithm, and I'm sure there will be on several of the other algorithms, some of which haven't really been reported to have been studied in humans as yet. So there will be more data for sure. What of course is needed is data on whether using closed loop and keeping babies in the target range more of the time makes a difference to longer term outcomes. and that there is a study ongoing on that, and that's going to be a hard question to answer.
Yeah. Okay, well, I'm going to wrap it up there on the hour. That's been a very, very informative and educational session. I'm just going to leave you with some thoughts, maybe from the pandemic. We have some, I think, groundbreaking randomized 6,425 adults with COVID-19 pneumonia in hospitalized, and showed a 20% reduction in the relative risk age adjusted of mortality in those 6,000 patients, compared with 4,000 of them had usual care, 2,000 of them had dexamethasone. So that's an example. Within 4 months, they were able to answer a very, very important question about mortality using a new form of randomized controlled trial, the platform trial, a multi-arm, multi-stage trial. And I'm sure that that's got some lessons for us in neonatology and in perinatal medicine. So please keep your eyes out and please stay tuned for more discussion on the use of platform trials and the use of multi-arm trials so that we can answer more than one comparison simultaneously. And I'll just leave you with that challenging and perhaps inspiring thought. I'd like to thank Julie for organizing, as always, this really exciting and innovative form of education during the pandemic. And Julie, would you like to tell us what's next on the agenda? What's the next topic for us?
I'm off sick, remember, William?